In my previous video, we learned about the rationale for various component preparation and its usage. So now, among them, one of the component cryoprecipitate, we will go little further discussion in detail about this special blood product which is usually made in the blood centers. The special because not every blood center generally do it unless there is really a need for it or something like that. So what is cryoprecipitate? Cryoprecipitate, as the name suggests, it is cryoprecipitate. That means something that precipitates in the cold. So that is how it gets its name, cryoprecipitate. It is also called as cryoprecipitated AHF or the anti-hemophilic factor or just cryo in some books or literature. So all these are same. So what is this cryoprecipitate? This was actually a discovery which was exclusively made to treat hemophiliac patients. Okay, so this was actually serendipitously discovered by Madam Judith Graham Poole. She was a physician scientist in a hemophilia center at San Francisco, and she was working on developing an assay for factor VIII. Okay, so while working on it, she serendipitously discovered that there is this factor VIII, which is basically when she was thawing the plasma for utilization in hemophiliacs. So she noticed that factor VIII actually thaws later when compared to all the other factors. So that is how she discovered that when you're thawing a plasma for utilization, factor VIII thaws the last. Okay, so she separated it. When she thawed it, she found that the supernatant had factor VIII concentration lesser than what was present in the sediment, okay, on the precipitate. So she separated it out, and that is when the cryoprecipitate came into usage. So to understand the utility of cryoprecipitate, we have to just go back a little and understand how it is actually prepared. Once we know that, it's very easy for us to make sense of how we are going to utilize it. Cryoprecipitate is actually prepared from an unit of fresh frozen plasma. The frozen plasma is taken and it is thawed at 4 degrees. Mind you, it is at 4 degrees compared to the general thaw for usage of FFP is usually at 37 degrees. Here we thaw at 4 degrees using what is known as cryo bath. Okay, it maintains the temperature at 4 and a circulating water is available inside this. And while thawing, initially the plasma thaws and a small sediment or precipitate is left behind at the bottom. This bag is centrifuged so that this sediment settles down and the supernatant is transferred into another bag, and this precipitated material which remains at the bottom is resuspended in around 10 to 15 ml of plasma, and that is what is used as cryoprecipitate or the cryoprecipitated AHF. So in one line, how it is prepared, it's thawed, FFP is thawed, the supernatant is removed, and that is usually called as the cryo poor plasma, and the leftover precipitous white material, which is usually rich in fibrinogen and cryoprecipitated, is separated out and utilized. So what are the contents of a cryoprecipitate? It contains plasma about 10 to 15 ml, factor VIII 80 to 100 international units, fibrinogen about 150 to 250 milligram, von Willebrand's factor at around 40 to 70 international unit, fibronectin, factor 13 at 20 to 30 international unit. What we have to remember here is, some people have a wrong notion that cryoprecipitate has higher factor VIII concentration or content than the FFP. That is not possible because cryoprecipitate is actually prepared from 1 unit of FFP. So its not possible that a cryoprecipitate has any of the content more than that is present in FFP. Okay, so usually factor 8 and the fibrinogen at a rate of around 70 to 80% of what was present in the initial FFP will be recovered, and factor 13 and all at about 30 to 40% of what was actually present in the parent FFP from which it is prepared. Okay, so the next question then comes is why cryoprecipitate at all if it is having actually lesser than what is present in FFP. I will describe this using an example here. Imagine there is a patient who is 40 kg, a severe hemophiliac, and his hematocrit is 40%. He has a factor concentration of 2 international units. That means to say, usually hemophiliacs who are bleeding or severe hemophiliacs usually have concentrate of the factor 8 less than 1 or 2%. Okay, and if you want to treat them from this hemorrhagic episode of hematoma, we have to at least raise their factor concentrate to about 50%. That is, usually 1 international unit of a factor activity is usually defined as that activity that is present in 1 ml of normal plasma. Okay, so if you want to raise it to 50% activity, it would be around 50 international units. So how do you do that? So blood volume usually calculated at 70 ml per kg. So patient's weight is 40 kg, so it will be around 2800 ml per kg. And plasma volume is usually 1 minus hematocrit, blood volume into 1 minus hematocrit. So hematocrit is here 0.4, so you'll get around 1680 ml. So the desired factor concentrate would be plasma volume multiplied by desired factor concentration activity, that is 50%, minus the present factor activity, which is around 0.02 or 2%. So that comes around 806 international unit. So this much of factor should be given to this patient. So now how do you give this? See here, if you want to give 806, and assuming that 1 bag of cryo has around 80 international units, you will need around 10 bags of cryo. Whereas if you try to correct the same with FFP, we will need around, each FFP contains around 180 ml, 180 international unit of factor 8, and you will need about 4 to 5 units of FFP. So now mind you, 4 to 5 units of FFP, each unit of FFP being around 180 to 200 ml, this would amount somewhere around to 800 to 1000 ml of plasma. Whereas with cryoprecipitate, 10 bags into 10 to 15 ml, which would be just around 100 to 150 ml. So now you can make sense that transfusing somebody with 800 to 1000 ml of plasma who is normovolemic is almost impossible. Whereas that can be easily done with cryo, because even if you give around 10 bags of cryo, the volume that you are transfusing is around only 150 ml. So that is how cryo makes a difference to these hemophiliacs. I will also take an example of another where you correct or use cryoprecipitate to correct fibrinogen. Imagine a 70 kg female has postpartum bleeding, DIC is suspected, and fibrinogen levels are at 60 milligram now, and hematocrit is at 40. So you want to raise the fibrinogen level. Usually the target is generally about 150 to 200 milligram per deciliter. That is what the target we usually keep at. So blood volume again, same 70 ml into 70 kg, that is 4900 ml. You calculate the plasma volume from the same. So now, again, the correction required is equal to desired level minus current levels. So the desired level, 2.94 liter is the plasma. That is again blood volume into 1 minus hematocrit. You will get around 2.94 liters. This is the plasma volume. So correction required is around 1.5 gram into 2.94 liters, that is 4.41 gram. The current levels in the patient is around 0.6, what you see here. So that would come around 1.76. So you need to correct by using at least 2.65 grams of fibrinogen. So how do you get it? So same, assuming a bag of cryo contains around 150 milligram of fibrinogen. To get 2650 milligram, you will need around 18 bags of cryo, whereas with FFP, assuming it contains 250 milligram of fibrinogen, to correct 2650, you will need around 11 bags of FFP. Again, the same problem. If the patient is still bleeding, probably FFP can be given, but if it's normovolemic, okay, if the volume status is ascertained and now the problem in the patient is only with the fibrinogen, then 11 into, again, as I said, 150 to 200 ml of FFP, which will be around 2000 mm, is almost impossible to give. Whereas with cryo, 18 to 20 bags of cryo would amount to around 200 to 200, say 300 ml of plasma, which can be easily given. So with these two, I'm sure that now you would have understood what is the importance of cryo and where it is to be utilized. Okay, don't be under the impression that cryo has more factor 8 or factor 13 when compared to FFP, but it is just this volume and logistic how you use, and which is not possible with the FFP. So now what are the current indications for cryo that we have? As I already said, hemophilia A, but mind you, factor 8 should be used, cryoprecipitate should be used only when factor 8 is not available. Okay, in the same way, hypo or dysfibrinogenemia, where active bleeding or peri-procedurally you can give to raise the fibrinogen concentration. Okay, the other utilization is factor 13 deficiency, where again there is active bleeding or peri-procedurally you can transfuse. Okay, DIC is an emerging indication. The other one, which are mostly used or resurgence of the use of cryoprecipitate, because nowadays hemophiliacs, most of them are treated by factor 8 concentration. So now burns and trauma. Okay, here is when, due to the presence of what is known as syndican 1, which is a glycoprotein, helps in the hemostatic effect in the patients who have trauma or burns. Cryoprecipitate is being used. And another indication where cryoprecipitate is approved or used is von Willebrand's disease with an active bleeding. Mind you, again, cryoprecipitate in von Willebrand's disease has to be used when the DDAVP, okay, that is desmopressin, is not available, or there is no adequate response for that, or it is indicated. Okay, and of course, the factor 8, which also contains von Willebrand factor, is not available. So these are the indications where cryoprecipitate has to be used. So now the obvious question is, why cryoprecipitated AHF is not preferred? Okay, the issues are, one is the increased risk of bloodborne pathogens with blood with the cryoprecipitate. We all know that cryoprecipitate, though our TTI testing and all have improved with available NAT and all that, we all know that the risk can never be 0%. There is some residual risk always present. Whereas factor 8 concentrate, which is usually a industry prepared, usually they undergo pathogen reduction and usually they are much safer than that. That is one important reason. Then the second is marked variation in the contents of cryoprecipitate, because obviously most of the blood banks do not prepare them regularly and the methods are little, I should say, crude, and this leads to marked variation in the contents of the cryoprecipitate. And the other is, of course, a slightly larger volume when compared to the factor 8 concentrates, which are usually comes in small vials nowadays. And obviously, if you can't give immediate cryoprecipitate or there is not enough and all that, so if you could not dose them properly, then there is inadequate hemostatic protection when compared to the pure factor 8 concentrate. And of course, there is stringent storage conditions required for cryoprecipitate, like -20 to -30, which many centers, especially the peripheral center, cannot afford due to various logistics, either non-availability of the equipment, the continuous power supply, and all these issues. Okay, mind you, the other thing, some common adverse effects can happen with cryoprecipitate. Usually, cryoprecipitate by theoretically can have all the adverse reaction that is seen in an FFP. But however, due to the sheer volume of cryoprecipitate when compared to FFP, usually reactions like TACO or TALI are much lesser in cryoprecipitate. The usual common ones are the allergic reactions, okay, rarely febrile reactions or so, and the infections that of course persist with that. So these are the usual common adverse events. Things like compatibility are not a problem because usually cryoprecipitates are given irrespective of the ABO group. People don't even mention the group on the cryoprecipitate. Okay. So that is, I will leave it here. Thank you.